Right, can we make a start with the afternoon session? I hope you've all been able to find something to eat and drink. But if anybody passes out, this is the best place to do it, other than Lewisham Hospital, obviously. We're now on to session 4, and we shall be hearing about the hospital closure proposals, downgrading of the A and E, and the effects on the population, the elderly, and the ambulance services. But first of all, Jeremy Hunt.
Minister, Matthew Kershaw's proposals included closure of Lewisham Hospital A&E. However, Sir Bruce Keogh's review recommended that a smaller A&E service should be retained. Why is that?
Sir Bruce was concerned that the recommendation for a non-admitting urgent care centre at Lewisham may not lead in all cases to improved patient care. While those with serious injury or illness would be better served by a concentration of specialist A&E services, this would not be the case for those patients requiring short, relatively uncomplicated treatments or a temporary period of supervision. To better serve those patients, who will often be frail and elderly and would arrive by non-blue light ambulances, Sir Bruce recommends that Lewisham Hospital should retain a smaller A&E service with 24/7 senior emergency medical cover. With these additional clinical safeguards and the impact this is likely to have on patient and clinical behaviour, Sir Bruce estimates that the new service could continue to see up to 3/4 of those currently attending Lewisham A&E.
And what did that review say about longer journey times for those seriously ill or injured people who would need acute services of A&E?
Well, Sir Bruce found no evidence that patients would be put at risk through increased journey times. Now, the whole population of South East London will continue to be within a 30 minutes blue light transfer to an A&E department, with the typical journey time being, on average, only 1 minute longer.
And what would be the benefit to those patients?
Well, nowhere in South London currently meets the London-wide clinical quality standards. As a result of my decision today, the whole of South East London will meet those standards, and it will have some of the highest quality care in London for people who use A&E and maternity services.
Thank you.
Brian Limbury will now give testimony to the Commission.
Good evening, good afternoon.
Good afternoon. Can you tell the Commission your name, please?
Yes, my name is Brian Limbury.
And your connection to Lewisham Hospital?
I've got various connections. I've lived in Lewisham since 1984, and I was born in Guy's Hospital, so I can regard myself as reasonably local. And I've had a long association with the National Health Service, both as a patient, because I was diagnosed 22 years ago with Parkinson's disease, early onset Parkinson's disease, and also in other capacities too. When I gave up full-time work, which seems a long time ago now, I became, after some searching around, I was interviewed as the lay member of the Lewisham Primary Care Trust. the North Lewisham Primary Care Trust. And then from 2002, I was chair of the larger Lewisham Primary Care Trust. And there, again, through all of this, the hospital was lurking in the background, doing its thing. But the Lewisham Primary Care Trust had responsibility for the hospital overall and for funding it. And so we had a lot of contact with them. And you wouldn't be surprised to know that in 2002, as today, there were concerns about whether A&E could cope. And there's nothing new in this case, except that our Lewisham Primary Care Trust, when it was talking about the University Hospital Lewisham, which was where the bulk of our money went, it determined that Lewisham Hospital had a case for survival. It's a large borough that it draws from, and there are not so many other good hospitals around. So we knew that whatever we were doing in 2002, we would be ensuring that the hospital survived through it to become bigger and better. And on that basis, we agreed with them that they wanted to get a grant, a PFI contract, I dare say, for the Riverside complex. But they planned it carefully, and so there wasn't the unfortunate circumstances that arise in the current case.
Can you please inform the Commission about the services that sufferers of Parkinson's disease require?
Yes, Parkinson's disease is an insidious disease. It affects most of the areas of movement in a person's body, voluntary and involuntary movement, and you never know what's going to come next. It creeps up on you, and when you think you've beaten one thing, another will come to take its place. And so it's a never-ending battle against the factors which are trying to slow me down, stop me, prevent me from getting on with my life.
Does Lewisham provide Parkinson's sufferers with an integrated service?
Yes, it does. And that's very important because a Parkinson's disease patient might need physiotherapy and speech therapy and exercise. I've had all of those this year, all in Lewisham. They might need help with getting about. They ultimately become immobile and need a wheelchair. So there's a great collection of different things that together encompass Parkinson's disease.
And does Lewisham work closely with another hospital to provide this service?
Yes, the Lewisham neurology staff are provided from King's, and King's oversees the neurology in Lewisham, King's College Hospital. And they have a specialist nurse relating to Lewisham, and she deals with lots of Parkinson's patients in the borough of Lewisham. A specialist nurse is a very good thing, but not every hospital has them. Not every hospital with a neurology department has one, because they know more than the consultants. The consultants only see their patients twice a year. But the specialist nurse can see patients whenever they need. And so she can give advice on medication. She can give advice on, it's usually a she can give advice on dressings, if dressings are needed, on exercise, on the various therapies which are part of the treatment package that Parkinson's patients might have. She can do all of that. And she does it well in Lewisham. And this has a tremendous effect on Parkinson's patients when they have need of help. And it prevents some of them from going into hospital.
Can I ask you about admissions to hospital? Are admissions to A&E frequent and necessary for sufferers of Parkinson's?
Some people go there very frequently, and they often have falls and suffer from the effects of that. I myself have fallen 3 times in the last 3 days, and it's several days a week, several days a month that I've fallen. And that has lots of effects on other parts of my body. And so for that you need the help of A&E. And what you need is a hospital which has staff who are not directly concerned with the patient's disease, but who know that the specialist attention is required and can help to deliver that. And that's very important. And the same links wouldn't be there if patients had to go to Greenwich for their accidents, because the treatment of patients at King's, the integrated treatment of patients in Lewisham from King's, wouldn't be there. And so the partnership between the Lewisham Hospital and King's Hospital would not continue, would not be able to continue in the way that it does now.
So currently you would say that there is joined up care for Parkinson's sufferers?
Yes.
Can you please inform the Commission as to what your view is about the proposals of the Trust Special Administrator, how that's going to affect people who suffer with Parkinson's in Lewisham?
Yes, I'll concentrate on how it affects people, but I would like to say before that I thought about it, and I started off being a little bit in favour of it, but I rapidly grew concerned as I read the documentation that there was no evidence worth looking at being provided to us. And so I found myself getting more and more strongly against the idea. And I don't see how an accident and emergency department in Greenwich, in Woolwich Hospital, can provide the support that Parkinson's patients need when they're not linked so closely to King's College Hospital. So,
the links that currently exist with King's will disappear, is that right?
Well, I think they'll atrophy, because there won't be the unity of purpose that there is now, because King's won't want to send its specialists out to Woolwich all the time. It's much further to go than Lewisham, from King's anyway, much more than a minute. They won't have the same knowledge of Parkinson's patients as they would have if it was Lewisham and King's. I go to the National Hospital for Neurology in Queen's Square, where they have a specialism in Parkinson's disease. And I go there because I knew I'd got a long haul, 25 years or more, of Parkinson's disease, and I wanted to be abreast of the most up-to-date medicines. But I use many of the clinical services, the therapy services in Lewisham. And as I've said, to cope with my falls, apart from anything else. And if I went to Woolwich, I wouldn't know anybody there. And they wouldn't know me. And yet in Lewisham, because I use Lewisham for much of my therapy.
And what would you say is going to be the impact on the actual health of those Parkinson sufferers if the A&E is closed?
It will be bad, because if you have anything wrong with you at any one time, it affects the rest of your systems. And so if you've got a cold, Parkinson's gets worse. If you fall over a lot, Parkinson's get worse. And so Parkinson's patients, they're not untypical of neurological patients. Parkinson's patients don't have it easy, and they wouldn't be able to establish the same sort of rapport with Woolwich that they now have with King's.
Can I ask you about consultation? Can you inform the Commission what your view is about the...
When I was chair of the Lewisham Primary Care Trust, we had a policy that we wanted to involve the patients in everything that was going on. And we never succeeded fully in implementing that, in achieving that policy. And we had a 6-year run at it during the time that I was chair. So it isn't easy to do, but we felt it was important to consult as much as possible. Even when we were closing down a nursing home or something like that, you had to take the flak. But the TSA seems neither to have taken any flak or to have put a set of proposals together, which makes sense. So I think that gives my view clearly.
But can you say whether, or is it your view that Lewisham Hospital did or did not have to adhere to the Trust Special Administrator's time frame for the consultation?
No, as I understand the legislation, and I hesitate to say this in present company, but as I understand the legislation, it was for specified health trusts that needed that attention. And Lewisham was never included in the designation of the 3 health trusts in Greenwich, Woolwich and Bexley.
So is it your view that there should have been much more time given over the consultation
Yes.
for Lewisham?
Much more time. Because without time, you can't get a sense of what all the people of Lewisham want. And it's only with time, or with long knowledge of the borough, that you realise that they are committed to having a hospital and making it a good one. And that's a good way for people to live, I think.
Well, I'm very grateful to you. Thank you very much indeed. If you wait there.
Thank you very much. Thank you. Okay, bye-bye. We shall now hear from Liz Aitken.
Could you, for the Commission, give your name and your qualifications, please?
I'm Dr. Elizabeth Aitken. I'm a consultant physician with a special interest in elderly medicine.
And how long have you been practising in Lewisham?
Since 1997, when I was first appointed.
What are the particular needs of your client group in the local population?
Clearly, although Lewisham, as has been said this morning, is a young borough, we still have many, many elderly people who have complex care. There are many people within the borough that live on their own and are very frail, with very high levels both of social care and of health needs.
Are you saying that they're at risk of social isolation?
And they're very much at risk of social isolation, which can impact on their health needs as well. They're a very, very vulnerable group, and obviously, in addition to those people living on their own, we have a high number of care homes within the borough, so a lot of patients in nursing homes and residential homes who also need, at times, an acute hospital care.
Can you talk a little bit about the general principles which apply in delivering care to a vulnerable elderly group?
So vulnerable elderly people often, they can have a simple fall, as been talked about very many times this morning and just now again by Brian, that elderly people will fall, and it may be a very simple fall, but that will impact on all their functions, so that they lose confidence, their mobility is decreased, and they therefore will need both physiotherapists, occupational therapists to go into their homes and give adaptations, see how they manage, social care to help them with some of their care needs, and also potentially a period of rehabilitation, possibly in their home, possibly in hospital, or else we also have some rehabilitation beds within Lewisham in our intermediate care facility, which the Trust manages all of those beds. So there's a whole team, and then there's the speech and language and everything else.
So you're saying there's a particular need for a multidisciplinary approach in
Yes, in elderly, with older people, yes.
And so what are the principles that you would apply in the context of independent living and restrictive or least restrictive forms of caring for the elderly?
We want to maintain people in their own homes for as long as possible, if that's what they want and it is safe for them. And obviously those principles require all the agencies working together, and it's a multi-agency approach. We have extremely good relationships with social care because we're in Lewisham. The social workers work with us on the wards to deliver that care, and extremely good relationships with the occupational therapists who work in the community and within the hospital. And many of our therapists work across the hospital and the community to give a streamlined approach so that patients are seeing the same patients both in the both in the hospital and in their own homes.
And what is the positive impact of that integrated approach in protecting vulnerable members of the elderly community?
I think that it gives patients confidence seeing people across the divide between acute and community. And also we've seen a decrease number of people being admitted since we've integrated with our community colleagues. Hospital isn't the best place for older people to be. We know that. They'll pick up infections and falls, and there are huge numbers of risks in hospital. So the ideal place is to have people in their own homes functioning, because also they will recover more rapidly. Particularly also patients with cognitive impairment and dementia, who the hospital is clearly the worst environment for them to be. And even if they live alone with some mild dementia, they can manage independently in their own surroundings if we give these people the right support. And also, you know, with their partners as well.
And how is Lewisham doing in maintaining that integrated approach?
I believe we're doing really well, particularly since we've integrated with community providers. We have more and more of these pathways. We have a team within the emergency department who will see patients who've come in, and we work as a team, both myself and all the therapists and social workers, to get people home rather than admitting them, or to our rehab beds, so that we actually have seen a decrease in our admissions. We have a stroke service. The acute strokes, as we've heard, go up to King's or down to the Prue to have urgent treatment, but then transferred back to our stroke unit within 24 to 48 hours for their rehab. And we have an integrated team, so the therapists come in from the community, help rehab the patients on the stroke unit, and then take these patients out earlier than they would in other trusts. So we have a much more streamlined approach. Similarly for patients who have a hip fracture, which again, obviously the average age of a patient have a hip fracture now is 85, so they're the very frail part of our population. We have an extremely good community rehabilitation team who will see, again, come into the hospital and take those patients out and continue their care in the community.
Thank you. How much time and work and effort and coordination goes into organising those networks and relationships?
I mean, as we've heard already, it takes a long time. It's taken several years for all of these pathways to be developed and be streamlined, and we're still working on making sure they run smoothly, and there's always things we can improve, but it takes a lot of time, a lot of discussions, a lot of meetings and planning.
Now I'd like to move on, if I can, to the issue of the impact of the TSA proposals on integrated care and care delivery for this vulnerable group. Could you give the Commission your views?
I think that the integrated care will be destroyed, because we won't be seeing these patients in Lewisham. The barriers will be much more difficult to get across. They'll be going to Woolwich A&E or even to King's, and if they end up in King's or Guy's and St Thomas's, it's much more difficult to implement those integrated pathways. They're certainly not going to see the same therapist or same doctor in the hospital as they would do in the community as they do now. So I think all those pathways that we've spent the last few years building will be destroyed.
And when you're looking at discharge planning and liaising with social services, will all those links and connections be destroyed?
Absolutely. I mean, we have very good relationships with our social care colleagues in Lewisham. What we have found is patients in Lewisham Hospital who from other boroughs have a longer length of stay, potentially up to 2.5 days. So it's a significant relationship,
So it would be right to say that, in your view, it's likely to lead to more costly, longer stays in hospital?
Yes, and the potential to get further infections and further acute illness and stay longer, yes.
Thank you. I don't have any further questions. The Commission may have some.
Thank you very much.
Chidi Ejimoku.
Oops. Oh well.
You can,
Yes.
you can pick. You can
It's okay. Should be okay.
Could you give your full name, please?
My name is Chidi Ejimofo.
And what is your role?
I'm a consultant in emergency medicine at University Hospital, Lewisham.
And what is your connection and your background in Lewisham and Lewisham Hospital?
I've been a consultant in the emergency department since 2009. Prior to that, I was a registrar in training at Lewisham. Prior to that, I've worked as a senior house officer, in other words, a junior doctor, and also as in a non-training position in the same hospital. In addition, my family have attended as patients. My wife works within Lewisham Borough and has an organisation that works with disadvantaged youth within the area.
And for the purposes of this People's Commission, what is your specific expertise and how can you assist?
Hopefully I can provide the Commission with some insight as to the workflows that we have within the A&E department, how we work within the borough and how we work with the patients that we have, and also some insight into the process or lack of process that the TSA engaged with the emergency department regarding those workflows and information.
So if we take that in stages, first of all, the people of Lewisham, the patients, how will these proposals affect those people?
Right. Our department sees over 115,000 attendances every year. It's a number that's going up fairly dramatically as well. The proposals allege that what is left in place will be able to see approximately 75% of those patients still. This has been challenged without any response to our challenges. We, and by we I mean the consultants within the emergency department and also with the backing of our college, that actually it would be closer to about 50%. So you are going to see in excess of 50,000 attendances having to go to other emergency departments within the area.
And what is the profile of the service users, of the patients? How would you describe them? What are the most common complaints and needs that are called for?
I'm fairly sure that it's been stated earlier on in the Commission. Lewisham is an area of high deprivation, has areas of high deprivation. It's a young community, but similarly has a lot of patients who are elderly, are frail, have multiple comorbidities. We have a lot of commonly occurring conditions seen throughout the nation, things such as COPD, heart disease, diabetes. We also have a lot of conditions because it's an area of, it's a very multicultural area. We have a lot of conditions that are native to our population. So you see a lot of patients with things such as sickle cell disease. You have patients who come back to the area with imported diseases such as malaria. These are all conditions that we treat very well within our department because we are used to treating these. Again, you would be looking at exporting these patients to areas that would not be as well set up to treat them.
So in reality, where will these people go with no A&E at Lewisham?
Well, it's interesting. Previously, somebody had, I believe the gentleman who was first here, speaking on behalf of Parkinson's patients, there had been a previous inquiry where the so-called a picture of health for South East London, where they had looked at where patients would go if there was no A&E in Lewisham. And all of the modelling that they showed pointed out that patients would, in order to take advantage of the public transport links, would have to go more centrally. They would need to go to places like King's, they would possibly go to St. Thomas's. That's where all of the links are. However, the TSA seems to take an opposite view, that people would easily be able to go to Queen Elizabeth Hospital, Woolwich. My understanding is that they believe that that would only involve a journey of, on average, 1 minute more. I think the people's personal understanding of that, and sorry to cite YouTube links, might beg to differ.
So in your view, where are they most likely to go?
They are most likely to go more centrally. They would most likely go to King's College Hospital, and when the picture of health was carried out previously, King's College Hospital were quite clear that they would not be able to they would not be able to deal with that increase in volume, and that volume has only gone up since then.
Okay. What about the ambulance service?
We've a very good relationship with the London Ambulance Service. Our emergency department has pretty much been a stalwart within South East London. It's been the place that has been known both by NHS London, by the control services in London Ambulance Service, as the department that you can fall back on when other places are overwhelmed. And taking us out would not only exacerbate, it would probably lead to a meltdown.
Can I ask you about the process of the TSA? What is your view as to the extent of transparency in the process?
Oh dear. With regards to transparency, I was not personally brought in or privy to the meetings. Colleagues who were essentially told, this is what is going to happen. Your comments may be invited, but they are not necessarily going to be taken into consideration, and they are not necessarily going to be taken as part of the final considerations either. In addition, the most interested parties, the various departments, such as the A&E, maternity services, pediatrics, and the rest, decisions appear to have been taken based on data that none of these departments had actually presented to them. So you had a process that not only was not transparent, but it was based on data that only they can tell you where they got it from, because they certainly didn't get it from us.
And finally, I know that you want to say something about the planning of the changes. And you describe them as a sea change. What do you want to say about that?
I think it's really important to state, the Secretary of State for Health had stated that we would be left with a small but safe A&E. I think it's really important to say that there is no such thing. It does not exist. We know what an A&E is. The College of Emergency Medicine has a fairly thick booklet which describes the services, the role, and the organization of an emergency department. There is one of the major things there are that you have to be able to see 24/7 undifferentiated patients no matter where they're coming from, whether they're coming via ambulance, whether they walk in by themselves, and for the full spectrum of medical problems. And in addition, you need to have 7 essential services in support of that A&E department. What they have stated is that Lewisham would lose 4 of those essential services: pediatrics, acute medicine, surgery, and in addition, intensive care. That is not an emergency department. That is not an A&E, safe, small, or otherwise. So this is a model that is known only to the Secretary of State himself and Sir Bruce Keogh.
Thank you very much. There may be some more questions.
Yes, just a corollary to that. I mean, if it isn't an A&E, what is it?
That's a very good question. It had been put to them that what you were describing is an urgent care centre. I note that they are loath to describe it as such because that would, I hate to use this term, would put a lie to the term that the Secretary of State has saved our A&E.
I just wanted to make sure I'd understood you correctly. You're a consultant in emergency medicine. One would expect when radical proposals to an A&E department are being proposed that a consultant would be consulted.
One would expect so.
You were not consulted, your opinion was not sought, the opinion of your colleagues was not addressed, listened to.
No, we were informed what would happen. Okay, thank you.
That was great.
Thank you.
Dave Newman.
Can you inform the Commission of your name
Yeah, I'm David Newman.
and your connection to Lewisham Hospital and why you want to give evidence to this Commission?
I'm a resident in the London Borough of Lewisham in New Cross, and I work in Forest Hill, but the main reason I wanted to give evidence was because of an experience we had with my mother earlier this year.
Can I take you then to that time? It's March of 2013. Can you just explain to the Commission of Inquiry what happened with your mum? If I just might say this. She was ill, she became ill with a chest infection, is that correct?
That's right, yeah.
And she was 92 years of age.
That's right, yeah. Yes, true.
So can you please inform what happened?
Sure. So Mum became ill in March, and her situation deteriorated quite rapidly one evening, so I was with her and needed to call an ambulance. She was unable to get out of her chair and couldn't eat or do anything else, so we decided that she needed an ambulance despite her resistance. And as was said, she was 92 at Christmas. She was born in Bermondsey in 1920, and that kind of meant that she grew up in between the wars and during the Second World War, so she knew exactly what it was like to live without an NHS. Her father, who died, my granddad, died when he was about 50. He had stomach cancer, but that went undiagnosed until it was too late, because in those days, if you didn't have much money, the last thing you wanted to do was get a doctor. And they couldn't afford it, so they didn't until it was too late. Anyway, going back to him. The ambulance came and they agreed that she needed to go to hospital, and she lives in Sidcup, which is about 10 miles out from here.
Sorry to interrupt you, but can you just inform the Commission whether there was a local hospital.
Yeah, I was coming to that. A few years previously, she would have gone straight to Queen Mary's Hospital, which is in Sidcup and 5 minutes from where she lived. But that A&E, which is obviously very significant, was closed down a couple of years ago. So the choices the ambulance crew gave us were Queen Elizabeth in Woolwich, Princess Royal in Farnborough, near Bromley, or in fact Lewisham. We thought that the Princess Royal was the easiest for her friends and relations to get to visit her, and she'd been there before. So we went there.
How far away was that?
It takes about 40 minutes to drive there. For an ambulance, half an hour or so. She wasn't being blue lighted, but yeah, that's the sort of time it takes to get there. And they set off. I arrived shortly after. We couldn't get into the A&E department. It was too busy. We were told that we would have to wait. Subsequently, I found out that there were 74 people in the A&E department. This is 10 o'clock on a Wednesday night in Farnborough. So we were put in a cubicle. Mum was in a chair. They'd given her oxygen to help her breathe. The ambulance crew have to wait with you until you're actually admitted to A&E. They're not allowed to leave you. They're still responsible for their patient. So we had an ambulance crew with us for over an hour or so, which meant they weren't able to go and do their valuable job. They were just minding my mum. Then eventually we were moved into the A&E department there. We weren't seen by a doctor. We just had to sit in the A&E department. And this is obviously getting quite late. Mum was very unwell, very, very tired, and was dozing off. And she had come round and she was quite distressed and asked to be taken home. Normally she was a very alert and bright person, but she wasn't aware of what was going on really. I think we waited there till about 1:30 or so before they put us into a bay, put her onto a trolley, and we got to see a doctor.
Sorry, can I just ask you, at what time did you arrive at the hospital?
We arrived about 10 o'clock in the evening.
So it was 1:30 before?
Before we was actually seen by a doctor, yeah. And he ran some tests, some blood tests, and she went for an x-ray, and he was very kind. And while we were waiting, I was talking to him, and he told me that they'd actually stopped ambulances coming to Princess Royal. So I asked him where they would divert them to, and he named a few other hospitals, and of course one of them was in fact Lewisham A&E that they were diverting the ambulances to, and the irony was not lost on us. So anyway, eventually they found that my mum needed to stay in the hospital. So at about 3:30 or so I left. She was falling asleep, and the nurse in charge said they'd find a bed for her. And the next day, my sister was going to go up there. She lives in Epsom, so before she made the journey, she would phone, but each time she phoned, they hadn't found a bed for her, and she was still in A&E on the trolley.
So how many hours is this now? Is it about 12 hours?
Well, yeah, it got up to about 12 hours. I finished work about 4:30 and went straight to the hospital, and by then they'd just found a bed for her. So in all, she was either in a porter's chair or in fact on a trolley for over 15 hours. And it's not only that that was awful for her and traumatic for her, but that meant that bay that she was in the A&E could not be used because she was in it, and they could only examine people in the bays. So that just exacerbated that situation. So my mum was very angry but tired, and really over the next few days she didn't improve very much, and she passed away the following Monday, so she was there for 5 days. And we promised her that we'd put in an official complaint, which we did. But I have to say here and now that we didn't put in a complaint against the care that she received. Everybody, from the ambulance, the nurses, everyone, the doctors, they were great, and she got good care. It was just the system that kept her on a trolley for that length of time.
Did you get a response, a formal response?
We did. I have a formal response. Eventually we got a response, and it was an apology and an acceptance that that was a bad situation, unacceptable for anyone, and they were going to investigate. But the reality is there was nothing they could do. They had 74 patients in A&E on a Wednesday night in Bromley, of all places, Farnborough. And we found out that they closed the hospital to ambulances for 90 minutes. We also found out that there were 12 patients waiting to be offloaded from ambulances that night. There was nothing particularly interesting about that night. It was just a night in the middle of March. So that the A&E was virtually overwhelmed that night. And it meant, patients were on the trolleys for a long, long time.
Can I ask you what your view would be about what the situation would have been following if the TSA proposals were implemented for Lewisham, closing Lewisham?
Well,
A&E.
I just can't understand how any argument can be made for closing any A&E department here in this area. If that situation on a Wednesday night in a suburban hospital is typical, with all those people waiting and ambulances queuing up, I can't see how closing an A&E or downgrading it, or however they choose to say it, is going to possibly help the situation. It could only be worse, so that more people will find themselves in that situation with loved ones being in a very, very traumatic and stressful situation.
Thank you very much. There may be questions from the Commission. From the panel.
Thank you very much.
Malcolm Alexander.
Could you please give your name and your particular area of interest?
Yeah, I'm Malcolm Alexander, and I'm chair of the Patients Forum for the London Ambulance Service, which is an independent group that monitors the ambulance service and has done for about 10 years. In the past, I also ran a project called Casualty Watch, which monitored A&E departments, and it actually started because King's A&E was a devastating and dangerous place for patients.
And how long have you been involved in these activities?
Well, in public involvement work since 1987.
So you've seen a lot of changes in the time that you've been involved?
Yes, I was the Chief Officer of Southwark Community Health Council, so I monitored services in the Borough of Southwark, yes.
And so, in your current role, how long have you been involved in Lewisham ambulance matters?
I haven't been involved specifically in Lewisham. The work we do with the London Ambulance Service is to monitor their work for the whole of London.
And have you had cause to have particular interest in problems faced by the London Ambulance Service in South East London?
Yes. There are considerable problems with the London Ambulance Service because they are understaffed to a very significant degree, and the number of cases which are coming to the number of patients is increasing rapidly. In fact, over the last year, there have been massive increases in the number of patients. A cut of staff over a number of years of about 500, and now the situation is so desperate that there is an attempt to recruit about 250 new staff. But that is because the conditions have become so bad for patients, especially patients who are more vulnerable.
Are you able to say what, in your view, are the pressures driving more increased admissions to A&E in London?
It's very difficult to say. I mean, nobody seems to understand the reason why there is such a significant increase in the number of patients who are dialing 999 and requiring ambulances. But what's become clear is that whilst the focus on those who are most seriously ill, people with heart conditions, stroke, major trauma, is quite efficient, for patients who are suffer from falls, who are vulnerable, who are in a precarious state of health, can sometimes wait many hours for an ambulance, despite the fact that the target for those category of patients should be about 20 minutes, 90% of the time.
Now, you've talked about understaffing, underfunding, and an upward surge in demands on the London Ambulance Service. What has been the government response to those, thus far, to those pressures?
The government response?
Yes.
Well, the government hasn't made a specific response. what has happened is that the ambulance service, in relation to particular pressures which resulted from the changes in North East London with Chase Farm because of the similar problems there, they called on a company called OHR to do a study, and that company has finished its study recently and has recommended that there should be a significant increase in the number of staff in relation only to there, not in relation to Lewisham, and that's a very important issue. There has been no study by the London Ambulance Service or the government in relation specifically to the emergency care demands on the ambulance service in relation to Lewisham. So what OHR have recommended is an increase of funding, which would pay for an increased number of staff and a change in the model so that every ambulance would have a paramedic and an A&E support worker. The problem being that at the moment many ambulances, well, the good thing is that many ambulances now have 2 paramedics or a paramedic and a technician. In future it will be 1 paramedic who is the most highly trained member of staff and an A&E support worker who is a member of staff who doesn't have, who's not registered as a paramedic and has much lower qualifications.
So you're saying, if I can just summarise, that the government's aware that there are significant problems within the London Ambulance Service. It has received recommendations in respect of...
The London Ambulance Service, yes.
Yes, it's in respect of one part of
yes.
ambulance provision. Are you aware that any of these matters have been taken into account before making the claim that only 1 minute's difference would be caused by the TSA?
I must say that that's absurd. There has been no study by the government or by the London Ambulance Service in relation to the increased pressures that would result from a change to Lewisham Hospital. There has been none. I have questioned the Secretary of State for Health, and I've questioned the Chief Executive of the London Ambulance Service persistently for the past 9 months, and I am absolutely certain there has been no study whatsoever in relation to the impact of increased pressures on the London Ambulance Service should there be changes to Lewisham Hospital. And if I might add, the really significant thing that I think is not quite well understood is that across London there are many long waits, it was mentioned by the previous witness, of ambulances queuing outside A&E departments. And just as an example, just give you an example of Bromley, the Princess Royal Hospital, University Hospital in Bromley. In April, there were 172 periods when an ambulance waited more than half an hour outside the A&E department. And in May, there were 152 occasions when an ambulance waited more than half an hour outside the A&E department just to get the patient into the A&E department. And I've got figures for the whole of London. Lewisham doesn't appear on these figures. There is not one single instance where Lewisham Hospital, where there was an ambulance waiting more than half an hour outside Lewisham Hospital to bring a patient in, although there may be instances of lower waits.
So, to your knowledge, have the authors of these proposals made any attempt to deal with these concerns or address these matters before making their claims?
Not that I'm aware of, and the significant thing is, every minute that somebody waits in an ambulance, in addition to what they should be waiting, every longer journey actually disadvantages another person who may have had a heart attack or stroke or a major trauma, because every time you load on the ambulance service additional work, additional waits, you disadvantage somebody else who might die as a result of those longer waits.
So how would you summarise the key impact on the ambulance service and on care provision and emergency care provision in light of the TSA proposals? Well,
I would say that the downgrading of the A&E department into an urgent care centre would result probably in a very significant increase in pressure on King's College Hospital, which has got no room to expand. I'd imagine that there would be significant ambulance queuing outside the A&E department at King's College Hospital, and there would be a crisis in terms of admission because they wouldn't have enough beds. So I think actually it's quite likely that people from Lewisham would go towards King's or perhaps Guy's and St Thomas's, and I think the pressures would be enormous. And referring back to Casualty Watch, when we started the Casualty Watch programme, there was very significant queuing inside King's A&E department. I've got pictures of the time, and it was, unbelievable to see the number of patients that were loaded into that A&E department for a very similar kind of situation, because nobody would invest appropriately in the development of that A&E department.
So in general terms then, would you say that the proposals would exacerbate the existing and well-known and recognised difficulties?
I think that it would exacerbate, it would increase morbidity and mortality. I think it would have a negative impact on people with heart disease and stroke because of the difficulty of not that they aren't a priority, but the more you load an A&E department, the more difficult it is to get the critical patients through the doors into appropriate places. The more the beds are full, and there will be consequent problems. And already, I mean, if we look at the situation, there are already inadequate attention to some people with stroke and heart disease because resources are currently insufficient, and that situation would become exacerbated with very negative consequences to the patients.
In other words, many more examples of the very sad story that Mr. Newman told the Commission about.
I think so, and you know, the particular issue which is so important is that as you get more emergencies in what's known as Category A, they're the people who are most critically ill, what happens is all the resources move towards Category A because they're the people who could die or could suffer from serious morbidity. And the Category C patients, those who have fallen, those with fractured hips, those perhaps with bleeds, other conditions, those with mental health problems, get neglected, leading to very long waits, deterioration, and sometimes people laying on the floor for many hours waiting for an ambulance and suffering considerable harm.
So you're saying then that this is not only the time-critical patients we have to be concerned about, but also the impact on those with less time-critical needs?
The consequences for less time-critical patients is grave.
Have you communicated your concerns to the TSA?
Not directly. We've to the Secretary of State and to the ambulance service, not to the TSA directly. No.
But you've communicated to the Secretary of State. What response have you received?
Well, we've received 2 letters which I've submitted to you, which really, I mean, the first letter I thought was pretty shameful in that it answered very few questions. The second letter attempted to give data to answer our questions, but I thought the data was very inadequate, and it finished off with a sentence that said, we can't answer any more of your questions because of the judicial review, which is imminent, which I understand legally is actually not correct.
What confidence do you have in the response you've received from the Secretary of State?
I think the response from the Secretary of State is shameful.
I've got no further questions unless Commissioner might have some.
Yes, it's on that same topic. You wrote 3 letters, and we've got the dates, and we've got copies of them, as well as the responses you've just mentioned. You were really wanting to find out what impact assessment had been made by the Department of Health with regard to the area you're concerned in, not just for Lewisham, but for the southeast area. So I make that clear. I want to deal with one of the replies that came to you, the last one, I think, on the 2nd of May. Do you have it there? So it's better if you've got it.
Somewhere, probably.
It's page 162.
All right, okay.
And the reason I'm asking the question is we do have to consider, just while you're turning it up, 162, middle paragraph, what it is the TSA and others are saying, and make an assessment about that as well. Now, they're saying in this letter to you this. Have you got it, 162?
Yeah. It starts, you also mention the impact.
Well, yeah, that's right, and it's the 3rd paragraph down. Your letter suggests. I just want your observations on this. Your letter suggests that there's been no impact assessment of the TSA's recommendations. The TSA commissioned a Health and Equalities Impact Assessment, which appeared at Annex L, I think that is, of the final report. An equalities screening document was published alongside the TSA's consultant and final report then considered the feedback from the TSA's consultation. The TSA's final report traces how he considered these various aspects before he made final recommendations. Does this make any sense?
Well, it doesn't, because I've questioned the Chief Executive, the London Ambulance Service, persistently and raised questions in their public board meetings on this matter. And they have repeatedly told me, and I've also spoken to Fiona Moore, the medical director, who is a member of the clinical team for the TSA. I've had a meeting with her, in fact, last week on the subject. And I have been persistently told that there has been no study by the London Ambulance Service, in relation to the impact should the Lewisham proposals from the TSA take place. So I am absolutely confident that although there may have been a study, that study is not specific in relation to the impact on the London Ambulance Service.
So this
has not been done.
A serious misrepresentation.
I think it is a very serious misrepresentation. It's a generalisation which doesn't deal specifically with the pressures on the London Ambulance Service.
Might I ask what an equality screening document would be?
Yes. I don't think I could really answer that question. I can't tell you specifically what that means. I think it's probably an equalities impact assessment that look to see whether any particular groups of the community would be people from an ethnic minority or people with a disability and so forth. I think that's what they're really referring to.
Yeah.
Thank you.
Okay, thank you so much.
Oh, is that yours? Oh, yes, your file.
That's my file.
There we are.
Okay, thank you.
We now have some more videos from witnesses who are not giving oral evidence today.
I think we deliver incredibly high quality of care to our patients. We're amongst the sort of fourth, fifth busiest in London, and we do so with less resources than some of the others do. I think we have real commitment around creating different roles for people, and one of the things that really got me back to Lewisham is the way everyone works together across professional boundaries, and that includes out into the communities, and not just doctors and nurses, but the whole range of staff and patients together. I think there's several risks to this proposal. Some of them are obvious, and I think a lot of people have talked about them. I think some of them are a little bit more hidden. I think we've failed, or the consultation certainly failed to engage with a certain part of our community. I'm sitting right now in the middle of New Cross. It's one of our more deprived areas. There's a big gang culture down here. And their voices no one will ever hear because they don't engage, generally speaking, with any services. But we see them in our department. And I think just for those people, the risk, they couldn't travel up to Queen Elizabeth. They would be travelling too many boundaries. I meet 12-year-olds who hardly can't go to their local school without taking a big detour because of gang culture. So I think that has really been lost beyond. I think some of the other risks is around the training. I run, and I'm very proud of it, a very successful emergency nurse practitioner team who treat about 25% of all patients coming to the emergency department, both adult and children with injuries. But we can only do so being part of that major team. What I can't see if we keep chopping services away and splitting them up is where's the next generation coming from? How are they going to train? When other providers set up urgent care centre, walk-in centre, those kind of things, they need nurse practitioners and GPs. There's a clear pathway for training of GPs. Where are we going to get the next generation of nurses from if they haven't had the exposure from the emergency department? And I think that's a worry. I think the deanery in terms of training medical students are a lot stronger than perhaps some of the other professional groups are. And I do fear that we're not going to have in a generation to start for the workforce that we need.
My experience of Lewisham Hospital goes back to 2006 when I was pregnant with my daughter, who was born at Lewisham Hospital. She had significant health problems and was very much under their care for a significant amount of her first 2 years of life. My son was born in 2010 and has more severe health problems and has also been a regular at Lewisham Hospital. But he has a significant and very rare and complex set of health problems. One is a complex congenital heart defect, and his second significant health problem is a liver-related diagnosis. Unfortunately, the second one has meant that Evan spontaneously vomits blood in quite a dramatic way, and it's happened 3 times in his life. That situation has been stabilised and managed by a special unit at King's College Hospital now, but at the time when this happened, we got an ambulance to Lewisham Hospital and they saved his life, and 3 months later he bled again and they did it again. And there is a risk that that may happen in the future, and there is a need for him to be treated very, very quickly, and our team at King's have said that we should be near an A&E, not beyond 20 minutes.
If you're homeless, you haven't necessarily got connections to the area you find yourself in, and you aren't necessarily registered with a GP. That means that if you find yourself with a health crisis on your hands, you're on the streets, perhaps you're homeless, you need to present to the local A&E department. And indeed, I can say that some of the folk that we meet will have had or have mental health issues. Whether you've mental health issues or not doesn't matter, because if you find yourself homeless, if you find yourself disconnected from your family, if you find yourself vulnerable and on the streets, and there but for the grace of God go any of us, and you were feeling depressed or suicidal, as these folks sometimes do, you would be advised to report to your local A&E department. And I think that has a huge bearing on what we're talking about today, because if you haven't got a local A&E department to report to, nor the resources to get to one, where exactly does that leave you? And it leaves you a bit more vulnerable than you were to start with. So I think our unique positioning within the community gives us access to such people, and I have a deep concern for them. The A&E department is the first port of call. If you have to say to them, well, we're going to put you on a bus to Bexley, or we're going to have to put you on a bus somewhere else, will they go? I don't know. Will they have the motivation to be able to go? I don't know. Will they then be seen as quickly as they need to be? I'm not sure. If somebody's suicidal and they've got that thought in their mind immediately, that's their only course of action, what difference will the delay make? Well, it might make a tremendous difference to that particular individual. And as much as we can talk to them and we can do what we can, sometimes people need professional help and they need it quickly, and we need to be able to get them to that point where they recognise their need for that. And it just feels like something's been taken away in the support for us and the work that we do.
In terms of Queen Elizabeth Hospital, I'm based in A&E, that's where my job is. And the A&E is just wildly overwhelmed, as it is before Lewisham shuts. And it's one of those things where I don't want to be scaremongering or damaging morale of like a good lot of staff there, but it's just too much work. And there was one day alone where there were 102 patients who waited 4 hours or more in A&E to get out. So that's for their length of treatment, that's not waiting to see a doctor. But you're meant to only be in A&E for 4 hours. There was a 98-year-old lady who came in with falls, who was there for 33 hours. She came in 8 o'clock in the morning one day, didn't go up to the ward till 8 something the next day, 8 p.m. the next day. And A&Es aren't equipped to deal with older people for a long period of time. Specifically to my job, which is drug and alcohol, the main risks I would see would be that the pressure on bed space in the hospital means that the vulnerable people I see, drug and alcohol patients, they fall down the list of people who are likely to get hospital admissions. So the typical kind of repeat presenter at A&E, who might be someone with ongoing liver or stomach problems, frequently relapsing with alcohol, who needs inpatient hospital care. When the bed pressure's on, they're going to, gradually marginalise and stop admitting those sorts of people and stop treating them as fully as they can, because the staff are under pressure to see other people. So specifically to my patients, they're less likely to get in. They're more likely to be left to sort of sit in a waiting area in A&E until they get pissed off and go home. and you know, that's the sort of thing where they end up presenting sicker further down the line and costing more money. It's difficult to know what will happen, whether Lewisham patients will struggle to get to the hospital if they're unwell, but what they'll definitely struggle with is getting home from the hospital at 3 o'clock in the morning, because they're not going to get patient transport.
Well, I want to assist the inquiry because I think it's crucial that child mental health services are linked to Lewisham Hospital. I mean, we have a very important role with helping young people who are suicidal and also young people who are referred from various departments within the hospital, such as dermatology, diabetes, oncology, you know, various departments and paediatric departments that are there. And the problem is, if Lewisham Hospital closes, then the link will be lost to our service. If young people are forced to go to Woolwich, to go on a bus 6 miles away when they feel suicidal, there's a problem with that. If they're then, you know, because what we would do if a young person is suicidal, if it's out of hours, we have to tell them to go to the hospital rather than contact us if it's out of hours. So the problem is partly getting to Woolwich, and then what happens if they're turned away, if they have to go to another hospital. But there's also a continuity of care with our service which is then lost, because we may not be able to, well, there's a debate, I think there's a discussion, would we then be able to go over to Woolwich and assess them, or would that then be with Greenwich Child and Adolescent Mental Health Service? So there's a problem of the continuity of care is lost.
What impresses me most is that the staff in Lewisham Hospital actually listen to you. You can see them listening to you. They're taking it in. They're thinking, what do I need to do as a result of this information? Do I need to refer to someone else, or is this within my competence? And you can actually see it ticking, see the process ticking. They're hugely committed, and I'm full of admiration for them. And in a sense, that's not just me as a parish priest speaking and someone who knows this parishioner really well. It's also as a manager. I can see as a manager that this is a system that really works. This is a system that motivates people. It runs intelligently. And I'm lost in admiration of it. This campaign is one of the most broadly based campaigns I think I've ever come across. It's got people who know about the changes in the NHS in great detail and in a sense who are more professionally involved. It's got people from the hospital, and it's got a groundswell of popular support. I think that makes it extraordinary. And it's right and proper that the church be involved in that as well. I don't think anyone's explained to us how a procedure that was meant to work where a trust was essentially going bankrupt, where emergency action had to take place, was supposed to be applied to a trust that's perfectly financially viable and nothing to do with the trust in financial problems. And I think it was the Secretary of State that assured us that this emergency process wasn't going to be a backdoor to reorganisation or reconfiguration. Well, in this case, it appears that that's exactly what it was about. And that, I think, hugely undermines confidence in the process.